Okay.
Hi, everybody. Welcome back. My name is Dr. Rebecca Griffith, and I am the ED DPT, one of many amazing ED DPTs out there in the world. And we are on our next episode of the podcast, Admit It or Not. And I'm really excited to have with me today Dr. Stacie Fruth. Hi, Stacie.
Hi, how are you doing?
Good. Can you go ahead and introduce yourself for everybody who may not know who you are?
A lot of people who don't know who I am.
I don't know, Miss. I have a textbook named after me.
Okay. Yeah, so Dr. Stacie Fruth, I am not an EDPT, but I spend my research days attempting to create studies and actually run them. So I was a graduate of the University of Indianapolis way back in the 90s and practiced a while in outpatient sports med. And that's where I got the emergency department idea and was denied by my supervisor at the time to even explore the opportunity.
Oh,
Then I got hit by a car.
what?
Yeah, and I was riding my bike. I was doing home health as well on the weekends at the time, and I had gotten my files for the weekend, and I was biking home, hit by a car, drunk driver. So I landed face first on a very busy road, tore my ACL, tore my rotator cuff, ripped my face apart, this and that and the other. But anyway, I'm sitting in the ER, as we called it at the time, and I know that my ACL is gone. I can feel it, and they were very, very insistent that that was not the case. That I had a patellar tendon rupture. Like, you're incorrect. So I fought with them a little bit, and then I realized quickly I was spinning my wheels and I wasn't getting anywhere. But then I'm just sitting there like, why isn't PT here? Why aren't we here? And anyway, so that's what fueled it a little bit more. Got hooked up with Michael Brickens at Indy University Methodist Hospital in Indy, and started talking to him, who had practiced there for quite some time at the time. Somewhere in there, I decided I didn't want to be a clinician anymore. I wanted to go in academia. So I started my doctoral work and needed a doctoral project and created the my first research project with Michael at Methodist, and then become faculty, and then that became my line of research.
So you literally have a doctorate in emergency department physical therapy.
Sure. Say that.
That's what it sounds like to me, and that's what your research was.
I like the way you think. Yeah, no. So I mean, at the time, nobody was doing any research at all. It was all just theoretical. I think Mike Lebec had put out a couple of descriptive, maybe, studies at the time, and but that was really it. It was, as I opened my defense of it, there's a paucity of research in this area, and it remains true, which drives me a little crazy. But
so speaking of that, how many publications are out there with your name on it related to this field?
Not many. How many are waiting to be written up? I have 2 with my name on it, actually. Presentation wise, I have a ton more, probably 15 or so. But along the way, I also realized it's really tough to run a good quality research study in an emergency department for so many reasons. Number one, we have a one-time visit. Number 2, just the general acceptance of PT in that environment. You get a lot of pushback for some creative ideas that you might have, like, no, we can't do that. We can't do that.
It's not on the algorithm.
Not on the algorithm, and somebody might die.
Right.
The ankle sprain might die. So,
or they don't need to be seen.
Right.
It's one or the other. They're either gonna die or they don't need to be seen.
Right. Yeah, we'll send them in a boot with crutches, and then 6 weeks later,
air splint.
Oh yeah. Well, either.
I don't know. I just, like, as a total aside, does anybody actually like those? They just squeeze the part that hurts. Yeah.
I know, but it's a fancy piece of equipment on my ankle that I can show people that I hurt myself.
Yeah, I think that is fair. So those are definitely some barriers to completing research in the emergency department. Other barriers that I've noticed that maybe you can help address are that if you're a clinician, there's, from my perspective, I don't really know how to do it.
Mhm.
I also don't get any time to do it, and don't have any mentorship or guidance on how really to get it through the whole process, let alone the things that you talk about, like the buy-in and the environment and the one-time visit. So what would you suggest people do?
Partner. So it's crazy. Like there's a deep need on both sides that isn't being met. So academicians, I'm not the only one with an interest in what happens clinically in the ED with PT. So there are plenty more. We have to do research. That's part of our job. We are mandated to do research. And just like everybody else, most people are going to choose the easiest path. And the easiest path would be a lit review. Or something outside of the ED that is easier to get subjects that you can just bring in and collect data.
Yes.
So academicians need the research studies and they need the clientele. We just can't advertise like we can. We can't put out something on social media. It's like, hey, if you're in the emergency department right now, would you like to sign up for a study?
Right. Also, like, how do you standardize your patients? Like I never even have the same patient twice.
You don't. Exactly. And that's why we have to study the practice and not necessarily the patient right now. We don't even know about the practice. The general the PTs out there don't know what we do, as you probably hear day in and day out from
trying to fix that.
Right, exactly, your purpose. So even if we just tell the story and get that out in publications, it at least helps the profession know what we do. When we're sitting trying to defend the House of Delegates statement, and even they don't know what we do.
Correct.
And you and I spent time describing various things so they would get it, but those people are at the top of our profession and we're fighting for them to understand it. So my big thing and push is we have just got to tell the story of what this specialty area does. And the high level research with standardized patients and really specific narrow descriptions that can come.
So what would you say to PTs that are practicing in the ED right now, even just about case studies? Like, is that a valuable way to spend your time? Should we be trying to publish case studies?
What better way to tell your story than to, everybody loves stories, right?
Yeah.
And that's what we do when we try to convince the public, or we try to convince fellow PTs or MDs what we do. We give them an example. For example, I was doing this evaluation and I caught this, and this is why it was important to be there. It's just a story.
I love that.
And so we keep telling those, and then it's like, oh, I know what they do in there. So it's been a big push to get at least some case studies published. There are none. We have 0 case studies, case reports published that have come out of the US.
That's crazy to me. And I can think of at least like 10 off the top of my head as a guilty party here of the case studies that would have been awesome to publish. So what would you suggest if somebody's listening right now and they're like, oh, I have the best idea for this? Like, what do they need? How do they even start?
Well, the beauty of a case report, and some of this is going to be, a hospital may say, no, we have to have an IRB. But in general, for a case report, case study, you don't need an IRB. IRBs are terrifying to people who don't understand them. They're generally no big deal. You just got to write up what you're going to do and prove that you're not going to hurt somebody, and then it's going to get approved. But if you don't need an IRB, that takes out a step that most people would be very, very glad to get rid of. So at that point, you need the patient's consent to get their medical records, because the medical records are going to tell multiple healthcare professionals and timelines and specifics of meds, or whatever the diagnostic test results would be. So they need to provide consent to release medical records to you as a PT or whoever. That can be done retroactively. So it could be, hey, I had this great case from a year ago, and I know how to contact this patient, and you give me the consent. It's much more ideal if in the moment you're like, you would be a great case study to write up. Let's get a consent form right now that you can sign. It's just busy PTs in that setting aren't going to think like that. They're going to think about, I got to get you home. I got to make sure everything's done. And then, 12 days later, that would have been a great case.
That would have been a great case study.
Right. So, and then it's a matter of you just methodically go through and pick out the parts that are important to tell that story in the tiny little bit of space that you have for, what a research study would be published. And that's really it.
So to you, what are the most meaningful pieces that people should include in emergency department case studies? Like to you as like a reader, or like what would be, and as an academician, if you're trying to teach this setting to students, what are those pieces of interest?
I mean, the most important thing is, why was the role of PT necessary? And or what was the collaboration? What did PT add to the team? What parts, what suggestions were given that perhaps prevented an admission? What little bells went off in the PT's mind that said, can we add a particular diagnostic study here to maybe prove that there's not any type of tumor or something other malicious going on. So I mean, the most important thing is when PT made a difference, again, either preventing admission, catching a diagnosis, doing differential diagnosis, a couple of different possibilities as to, well, it could have been this and it could have been this, but I did this test practicing at the top of my license, and it resulted in this, which then in some way helped the patient.
Or even like maybe like a case series on application of the auto ankle rules by a physical therapist in the emergency department to reduce imaging.
Yeah, I mean, and
I would read that.
Yeah, a case series is also an easy to read thing. So it's easy to read a story, meaning a case study, case report. Case series is just a series of snippets, right? That tell the same story in a different way, that generally come to the same conclusion. And again, not a difficult thing. The difficult piece is gathering that information, making sense of it. But that's where partnering with the academic side of things, that's what the academic does. And so the clinician's job really is, you got to do the legwork on the side of the hospital. I can't ask for consent. I'm not a part of your hospital system.
Right.
So getting that consent and getting all the information gathered and distributed with permission to the right people, the academic is going to ask for your opinion. Like, what do I have to look for? What do I have to really highlight here? But then they do the lit review. They do the, writing up of whatever it is. And then the clinician becomes part of the authorship team. And whether that's just a professor, or it could be a professor working with students, which is what I mostly do with my student research group. The clinician is clearly part of that authorship team, because without that input, it really wouldn't make sense just to have this stack of papers handed to you.
That makes sense. So by partnering, we can help get the story of emergency physical therapist practice a little bit more out there in the literature.
Right. And I, for whatever reason, I, despise the phrase low hanging fruit, but yes, everybody would like to do a randomized control trial. Everybody would like to do a study where there are 50 participants, but to do that in an ED environment when you typically have one PT, maybe two, who are busy all the time, who don't have time to walk around with consent forms and to sit down and make sure that the participant is okay, all these grand ideas kind of become unrealistic unless there's some substantial grant funding where somebody is paid specifically to do that for the study.
Correct.
A whole nother category of things.
Wow. So a lot of like practical barriers to doing research in the emergency department, but some good solutions on ways to get started.
Right. Exactly.
Do you know of any hospitals now that are actively doing randomized control trials in the emergency department?
I am not aware of any. That does not at all mean that they aren't happening.
I only know of a couple. I think Brown maybe is doing some research on falls prevention with physical therapists in the emergency department. And then I think Northwestern is working on a low back pain protocol for the emergency department. So that's all I really know about. But if anybody listening knows of other studies going on, I think you and I would both be interested in hearing about that.
Right. And I would be interesting if that's true about coming out of Northwestern, if they're working on protocols, that still doesn't involve patient recruitment, does it? Again, that is the hardest part is, so a study that I did, one of the studies several years ago, asking about patient satisfaction, the simplest things. We presented it at a variety of CSMs. But even just getting that follow-up phone call, them to answer the phone call about, can you tell me about, were you happy with your experience? Do they still have that phone number? Will they answer the phone number? Do they even remember that they signed the form saying that you could call them?
Do they even remember being in the emergency department?
They remember being in the emergency department. Yeah. And so, and in an emergency department, their emotions tend to be higher
100%,
and
yeah.
Their thought process of, oh yes, I can enroll in a research project, and they're like, no, I'm just happy I'm not dying, I want to go home. And there's just a little less willingness, I think, through no fault of their own.
Right. It's a critical moment for them.
It's the environment.
Yes, we'd like to ask you just to answer a few questions about one of the worst moments in your life today. Yeah, I think we actually in our last pilot study did ask people about their patient satisfaction, but these are mostly patients coming in through like our fast track area where they really should be fairly well in ambulatory and not like undergoing major trauma, but the perception of patients is still that it's a major issue most of the time, even if it's not life-threatening. But I was surprised at how willing people really were to participate with that. It was just a simple like 0 to 5 scale, like very dissatisfied, very satisfied. And we didn't really have a lot of trouble with that. What I did find was patients really wanted to write comments. And so we're able to collect a lot of like, I don't know, what would you call that, Dr. Fruth? Is that qualitative data? When they write in comments?
Let's call it yes.
I don't have any idea.
It's not quantitative.
Nope, it's not, but it's like still a piece of the overall picture, right?
Yeah, I mean, it kind of probably falls more into descriptive.
Oh, there you go. That's the right word.
I mean, so yeah, the qualitative would be doing analysis on the themes of what
that makes more sense.
But
see, this is why we need you.
I like speed every now and then. Yeah,
it's like you're a total professional and you know exactly what you're talking about.
My students might not agree with that, but that's okay.
So tell me where you think that emergency department PT should go, because I know you have lots of ideas about types of research that should be done, but like ideal state, what do you think this looks like 10 years from now?
Independent practitioner in that environment. So we have direct access in some crazy form or fashion everywhere. Whether it's used or not is a whole nother story.
Yep.
But barring the fact that it doesn't go away, it's only going to slowly get more and more and more. But even if there's the best direct access in any given state in the emergency department, that's taboo. It just doesn't happen.
Correct.
Anywhere. It doesn't happen anywhere because of EMTALA. The part that the physician or PA or NP or whoever is designated that is capable of doing it.
So for people who don't know what that is, can you just explain what that is?
EMTALA is a federal rule that basically states that a patient who walks into or rolls in or crawls in or appears in the emergency department will be evaluated by a medical professional that is designated to do so. And whoever is designated to do so is defined by the hospital system. That it is not a federal mandate. It's just whoever the hospital system designates. Well, this EMTALA evaluation typically consists of a typical neuroscreen. So we're going to screen cranial nerves, we're going to do reflexes, we're going to do strength, we're going to do just the standard stuff that PTs already do, that we're already trained to do. But we can't seem to get ourselves on the list of approved providers to do that. And so another problem with the research is we can't do a true comparison of PT only care versus MD only care for the same diagnosis, because an MD or PA or whatever always has to be involved in the PT managed care right now. And so first and foremost, to be able to prove we are well trained and accurate, reliable, valid to be able to do deep tendon reflexes and sensation, and I can see if your pupils dilate. I teach this stuff in the first year of the PT program.
Correct.
I mean, now it might not be pretty the way they do it, but but we can do that. So that's one thing. And then genuinely practicing at the top of our license. It's, we have fought for this to be able to do the hard differential diagnosis, to be able to prescribe, maybe not narcotic medications, but at least some of the other meds that are very frequently prescribed, to be able to order, plain films, to be able to order CTs, MRIs.
Durable medical equipment.
DME, exactly. And so, I think, yeah, there are some areas where PTs will definitely need more training. Generally coming out of school, you're not going to be able to do a really good read of a CT or even a plain film. But that's a day or two long continuing ed with a competency at the end.
But I would argue a lot of emergency department physicians rely on radiologists to do that piece of it as well. Of course
they do. But we won't be granted the privilege until we can show that, yes, in fact, we do have that ability.
That's fair. I mean, that makes sense to me.
Right.
I totally agree with you. I think there was a motion at the House of Delegates this year to look at a feasibility study for prescriptive authority, for the expansion of prescriptive authority for physical therapists, including up to narcotic medication, movement-related medication, durable medical equipment, imaging. And it was actually referred to the board for further review. And I was one of perhaps the outspoken people who really feel like this is an important thing for us to stop and discuss. And I think some of that is because I do practice in the emergency department, and those limitations really keep me from being able to fully do my job without the outside assistance from another provider. And one example of that is if I evaluate and treat a patient with low back pain and make recommendations to the physician or the physician assistant or the nurse practitioner, I often get asked, well, what should I give them? Do they need a muscle relaxer?
Right. Oh, yeah.
Well, I mean, no, like I mean, that's up to you, but my evaluation would indicate this is not muscular, or my evaluation would indicate this is a nerve related issue, and then they are making decisions about medications based on my examination and evaluation along with their own. But those are questions that I get frequently. I also think there is absolutely no reason that I should have to tell a physician what type of durable medical equipment a patient should have. And then I have to write a letter stating why they need that. But the physician also has to write a prescription for that. Like, that is so much excess that should really be drilled down. When we talk about like the excessiveness of our healthcare system, that is one area that should just be a no-brainer.
Yeah, I mean, without a doubt. And we look to, and you and I have had this discussion multiple times, we look to our counterparts from across across the pond, or to our north,
or in the military,
or a lot of other places, right? That have that privilege, or those sets of privileges. And yet we are the highest educated physios around the world. So trained at the doctoral level, and these other countries, the UK and often Australia, New Zealand, Ireland, Canada, they are trained at some the bachelor level, and then they just get advanced practice training to become an advanced practice practitioner. And they are able to see patients independently. They are able to order films and order meds, and some of them are able to do injections. The gamut. And so we just sit over here and scratch our heads as to, I mean, we all know why, and it's the politics of the mighty dollar.
Well, and they're doing that without like adverse events.
Yeah. Oh yeah.
So it's not even like they're just doing it haphazardly. Like, that's been studied and published, and they are safely providing that.
Yeah. Or else they wouldn't be able to continue that. But the healthcare system is so different that there's often such long waits. They are desperate to do anything to get people through the system faster and faster and faster, so there's less of a wait. And here our belief system and our priorities are just different.
Correct.
And and knowing we can't fight that
yet.
Well, I mean, the efforts are there, but like, there's nothing I can do about that today that's going to make a difference tomorrow. And so we work with what we have and try to beat the system in other ways to be able to show that, yes, in fact, we are capable. And I mean, and honestly, the rest of the medical profession doesn't even understand what it means that we're prepared at the doctoral level. They just don't. They don't know what our training is in school. I remain just completely appalled that there just isn't more information being shoved out about what PTs do and how we're trained and what we're capable of doing.
I had one of my attendings say to me, "How come I had to learn that you were a doctor on Twitter?" And I was like, well, just a heads up, every physical therapist that practices here is a doctor. And this is what that means. And so after that, in our education to our physician partners, we really did give them that education about what was within our scope, what was not, like what coursework we had taken. And now part of our algorithm when we're seeing patients is that the physician who does the triage will say, you will next see the doctor of physical therapy, so that they're setting that expectation for patients as well. Well, Stacie, I appreciate like all of that information, especially that really helps frame why it's necessary for us as practicing clinicians to get our story out there so we can help move us, I don't want to say forward, but to help us catch up a little bit with our partners around the world.
Absolutely. By just doing what we do.
By just doing what we do and writing it down. And it doesn't have to be scary, like you said.
Right. Yeah. And I think, none of us has copious amounts of time, but the other question is like, why aren't we presenting at emergency physician conferences?
Yes.
Why don't we have a presence there? Okay, well, there are other barriers that, I won't bother.
I have found acceptance as a barrier.
Well, I mean, yeah, it is true. I mean, you also have to be a member. So you can't just come up with a study, as great as it might be. You have to have a sponsor,
correct,
who is willing to then submit. And so that, again, there's, as soon as you hit too many barriers and you're already out of time and you're so far behind with everything else, you're just like, I can't do it.
Exactly.
Yeah, and I think we just rinse and repeat that all the time.
Well, thank you for motivating us to hopefully be a little bit better about that.
Yeah. Oh yeah. Absolutely.
All right. So at the end of every one of our podcasts, we always have a case. So are you ready for the case?
Am I the one I'm presenting?
I'm ready.
Okay. All right. I will first fully credit Michael Brickens for this. So Michael, who practices in Indianapolis.
And Michael, if you're listening, would love to have you on the podcast.
Right.
Hint, hint.
Yeah, I think he's easing off some of his practice, and rightfully so. He has done such amazing stuff over, I can't even count how many years he's been.
He's an OG in the ED.
Yeah. Oh, for sure. Yeah, he was one of the founders. Absolutely. And so kudos to him. But this is a case that we presented at CSM some years ago. They all blend together. But basically the story, as I'll tell it, was a gentleman who was overweight, came in with a leg injury, and was seen by, I'm not going to get the details exactly right, so I apologize. Okay. Was seen by physician or physician assistant, and I don't know, probably some standard films were taken. Nothing was found to be substantially wrong. Patient was sent home. Either a fall happened or something else happened to bring this patient back. Was evaluated by yet another healthcare professional. Nothing really was found. Was evaluated by another healthcare professional. Nothing was found that was substantial. We're going to send this patient home again. At some point, Michael got involved and asked to see this patient. So I think Michael was talking to, it was either an EMT or somebody that was involved in this person's care, and something clicked. And I just give me a chance. Just let me in there. And
what's it gonna hurt, right?
Right. And lo and behold, quad tendon rupture.
No.
Right. So they were going to try to, I remember now, I think it was an EMT. I don't know why, but EMT was instructed to gait train this individual with a cane. And
I don't like that.
No, I don't like it either. Right. And so, I mean, huge fall risk. And, so I do
Was
believe.
any bracing provided?
I don't believe so.
Okay. Red flag number 582.
Well, until Michael got involved. Yes. And yeah, so definitely different choice of assistive devices, bracing, and if I remember right, I believe a surgical
consult.
Referral. Yeah.
Okay, so in this case, patient presented to the emergency department, discharged, bounced back, went through everything again, same workup, almost same result, only this time let's throw a cane at it, like darts, until the physical therapist got involved, in which case we were able to differentially diagnose, provide appropriate stability, provide appropriate durable medical equipment, and make appropriate referrals for further care, thus preventing an admission, allocating appropriate resources, not allocating inappropriate resources, and hopefully preventing another bounce back to the emergency department.
Yeah, and when we presented this, we presented like the timeline and just the insane amount of hours that went by for this person to finally get the right level of care, and that right level of care was provided by a PT.
I love that. So another great example of why physical therapists are definitely needed in the emergency department.
Absolutely.
Thank you so much for your time today. I really appreciate hearing about your work in research and your early work getting involved in the emergency department. Thank you so much. Any final thoughts for us?
Yeah, I mean, if you're a PT, if you have some of those great case study ideas, contact your local university. And maybe there's not somebody interested there, but I guarantee you academics need things to research, they need things to write up. And so it might take you a couple of phone calls or emails. But that's what we do. That's why one of the reasons why we chose academia was to conduct research. And so that's what I would encourage to help us get that story out there, because there's so many to be told, and it's just a travesty to me that it's right now our story is silent.
Well, and I think there is this like perception on behalf of sometimes the people who are in the clinic and academia that it's like this us and them situation. Like, well, they don't teach it how it is in the real world, but like, how are you supposed to know
True.
what it's like in the real world if we don't partner? So I really like that suggestion.
Yeah. And guess what? Us in academia, we realize that we don't necessarily teach what happens in the clinic. But guess what? There's this thing called CAPD where we have to
Definitely.
And we have to, that's a whole nother, don't get me started.
But you also have to, I mean, you also have to teach the basics and the foundation, right? On which you then apply the craziness of the real world.
Well, we also have to teach it in a very standardized, very sterile way for this, for the students who are just starting to understand.
Yes.
And in no way do I assume that everybody is going to go out and do the very exact little goniometry things that I teach, because I have to teach it that way.
What is a
I know
goniometer?
I teach it. I have vowed not to teach it ever again, and yet I'm going on year like 14 of teaching this stuff. I haven't picked up a goniometer in practice. Who knows?
Well, I have to tell you, for those of you who are listening, who are in the clinic and who have said that, like, well, they just don't teach you how it is in the real world, please become a clinical instructor, because that's where that happens. That is where that education happens. And if you're practicing in the emergency department, I doubly ask you to consider taking a student, because if we want this area of practice to continue to be well known and well practiced, then we need to have more students that are exposed to this clinical practice.
Absolutely.
All right, well, thank you all for listening today. I appreciate it. Please share, like, and subscribe so we can continue to bring you content around emergency department physical therapy, and have a great day.